We're going to do the multifidus lift test. Multifidus is palpated easily just off the spinous process. Once you get a little bit too far, that's the paraspinals, and remember, it's just, very dense here. So the first thing you're going to do is just palpate to see if you feel a little less tone on one side compared to the other. So we're going to do that with the patient, and then we're going to do shoulder flexion, contralateral shoulder flexion. By doing contralateral shoulder flexion, you're going to feel the multifidus kick in. So I'm going to palpate here to see if there is a lag. The research has shown, and it's been recent too, that a therapist can palpate the lag and the atrophy of the muscle is visible on ultrasound, or the lag is visible on ultrasound as well. So what they did is the multifidus lift test with palpation and had a therapist palpate it, and then also did an ultrasound to see if they could see the lag on ultrasound. And it's like one of the, I don't know why it wasn't shouted to the rooftops, because it was one of the only things in the past 10 years that showed that we could palpate something and it was validated by something else. So I think we should celebrate that personally. So this is the multifidus lift test. The core was first brought into into notoriety when they were looking at firing patterns for the shoulder in the 90s. So this is an extension of that. So when we're doing the multifidus lift test, we're going to start with palpation. And we're going to try to palpate tone and see if the tone just off the spinous process is less on one side compared to the other. Now we have to get good at palpating tone. And I have told this story many times, but if you take your hand and palpate your thenar eminence, I learned this from Chef Franz at the Continental Dining Lounge on how to cook meat. So if your hand is in a relaxed position and you palpate your thenar eminence, that's rare. And then if you oppose to your index finger and palpate, that's medium rare. So Chef Franz would palpate this, palpate the meat, palpate that. Okay, that's medium rare. Oppose to your middle finger, that's medium. Oppose to your index finger. Again, the tone is increasing, medium well. And then to your little finger, well. So that's the tone. So what we're going to palpate is looking at something that's medium to medium rare on one side and medium to medium well on the other side. So that's what we're looking at as far as when we're doing our palpation. Technically, your thumb has less sensation in it than your fingers. And I will use my thumbs, but you have to realize your fingers are going to be a better indicator for you finding tone. The thumb is designed for three-dimensional representation of an object through stereognosis. So you're basically always, this is the axis, and all the fingers work around it. So the sensory representation of the thumb is less than the other fingers. So you have to think about that when you're doing your palpation as well. I learned that from Diane Lee. So when we're palpating, we notice definite decreased tone on this side. So he's medium, medium rare on this side, medium well on that side. So my hypothesis would be that he would have a lag on the left when he raises his arm up. So I'll have him raise up. I always like to start with the other side. So go ahead and raise your, come on back down. Raise your left arm up for me. Good, and come on back. And raise your right arm up. And you're palpating to see if there's a lag. Sometimes it's subtle, and sometimes I want the patient to feel it. So I'll say, okay, can you take your hand and feel? Yeah, there we go. Some people have no shoulder range of motion to do it, but he does. So I just want you to feel that muscle kicking in. So go ahead and push into my hand. You feel that? Good. So this is a muscle we're going to retrain. When you're reaching, even to get a cup of coffee, sometimes that muscle isn't coming in first. That muscle should come in first. Your body, subconsciously, you think, I'm going to move my hand. The body says, oh, I'm taking 7.5% of my body weight and putting it in front of my center of gravity. My trunk will fall over unless I do something. So what it does, it brings in the multifidus. So I think I'm going to move my hand. Multifidus kicks in first, hand moves. That's the neuromuscular pattern. When you lose it, and that doesn't kick in, then you're going to have more extension, which is going to bring you outside of your neutral zone more. Now, for fun, palpate on that other side. Come in a little bit more there. Good. Now raise your hand. You feel that muscle. Good. And then when you push into me, you feel it too. Okay. So there's definitely a lag on this side compared to the other side, but I use it as a training for the patient as well. So that is how I perform the Multifidus Lift Test in standing, because I think it's more functional. Now we'll go to the traditional performance of the Multifidus Lift Test. So go ahead and quadruped. So the traditional performance of the Multifidus Lift Test, they usually are using their thumbs. And then what you have the patient do, go ahead and raise your right arm for me. Good. And come back and raise your left arm. Good. Okay. Now notice, like even without me palpating, go ahead and raise the right arm. See how he drops? Come on back and raise the other arm. And he's a little bit more stable there. So you could, quote unquote, do your bird dog if you want in this position. But you would feel that when he, go ahead and raise your arm on the right, he drops right away. So he has a lag on that side, which kind of fits in on our hypothesis. We could also have him raise his leg, which would fit in that same hypothesis as well. My problem is this is like bird dog, and we're going to have to retrain that non-dropping, which may translate into better weight-bearing movement, but maybe not. But if he's not on his hands and knees like a plumber or doing different things like that, or a ship fitter or something, then why are we giving that as an exercise program? Because he's still going to be moving, he's still going to be lifting and reaching. Go ahead and lie on your stomach. An alternative way, if you were working on retraining as well, is now you bring your hands above your head, like you're Superman. Not quite yet though, yep. So then what you can do is palpate, again, just on either side, and go ahead and raise up your right arm, and then your left. And you can feel that difference too. Go ahead and raise up your right arm. So when he raises up his right arm, he kicks in here, but not as much in here. When he raises up his left, he kicks in great here and subtly here. Raise up your right leg. Drops on that side again. Raise up your left leg. Perfectly fine. So we can, that dysfunction, whether we looked at it in weight-bearing or non-weight-bearing, his neuromuscular system's not keeping the neutral zone, and part of it is this multifidus isn't timing well, isn't kicking in well. So we need that to kick in automatically. Do you think 3 sets of 10 is going to cut it? I need you to do the bird dog, 3 sets of 10, because that's going to help this. No, how many times is he raising his arm in a day? So what you need to do is increase awareness for the patient. You told me when you came in that one of the issues you had is that when you were reaching for things, especially overhead, you were feeling pain. And so we can work on a pelvic tilt for you, but part of that problem is you're not able to hold that. So I need you to bring this muscle in a little bit better. So one of the ways we can do that is actually have you hold your hand right there. I need you to feel this muscle right here. Good. So you feel this muscle, go ahead and push into my hand. You feel that? Okay, so now I need you to keep that muscle tight and relax the pressure off my hand. And we'll go through a series of strategies, whether it's lumbar spine position, not locking in the knees, shoulder position, cueing the pelvic floor to make sure that when he takes that pressure off his hand, and I have them like push into a wall or something like that, that can stay in and he'll have that awareness. So eventually he'll be able to have his hand here, tighten those muscles and bring that muscle in, which leads to him automatically tightening his core. Now, I'm using the contralateral multifidus as a access to the core. Don't be confused with the fact the core works simultaneously like a piston with the diaphragm, pelvic floor, obliques, transverse abdominis, and multifidus. I'm just using this as my access to resetting his core because that's the easiest thing for me to train at this point. If they have pelvic floor dysfunction, sometimes they need to see a women's health specialist. I can't help them with that. That's not in my skill set. But if they're having trouble with core activation and they might have some pelvic floor dysfunction, once they get that trust with you, maybe they'll mention that. And then they need to get that addressed because then they're fighting an uphill battle because that's what's shutting down their core. So we need to be able to interact with other professionals outside of our skill set, especially when it comes to this. Okay, so in summary, we started with extension range of motion. Looking at that range of motion, finding part of that initial cluster for the person not being able to be in their neutral zone, having pain with movement. We then went to our extension pivums to see if there was something that was either not moving enough or maybe moving too much. That extended to our anterior shear test for confirmation and working on what we would do for a home program. And then we went to the Multifidus Lift Test because they're going to have neuromuscular control. So when we're dealing with our hypermobility person, that's what we're looking at.